Let's talk about the number 8 ML and DL that we're going to do in lab. The tooth that we're working on is called 11F, and that's what you'll see on the root surface. It has both ML and DL decay located on this central incisor. So this is going to be a good opportunity for you to place an anterior rubber dam and get that checked off if you haven't done that yet. The first thing that you're going to do is prep both of the class 3s to ideal, and those are going to be based on the criteria that we're using, the regular ideal criteria for our practical. We'll talk about that here in a little bit. After you prep to ideal, you can talk about that with your instructor and get some feedback. And then you're going to expand the outline form. This is a little bit different than maxing it out. What I want you to focus on is moving every wall until you don't have decay on it. It's a little bit different for a class 3 because you are kind of just expanding it, kind of like you are to max. But your goal in the end is to remove all the decay. If you have some decay going in on the axial wall and it's heading in a direction that is more pulpily, really, if you move the incisal wall and gingival wall and facial wall, you're not going to hit the pulp. If you're moving the axial wall, it's a little bit of a danger zone. And so if you feel like you're moving it far enough that it's probably a good idea to switch to a big round burr in a slow speed, this is where you're going to be able to do that. And normally this would require, a chat with your professor just to make sure you're on the same page and you know everything that they want you to remove. But it makes a little more sense. It's a little bit more conservative. You could do it with a spoon excavator as well. But I think that this black decay in these Kilgore teeth comes out a little bit better with a round burr in the slow speed. You want to pick the biggest round burr that can fit into the prep that you've created. The reason that you want to do that is because it takes a lot of pressure to push a big burr through a pulp chamber and a little bit of pressure to do that with a small burr. So you want to avoid that. So pick the biggest burr that you can to remove that decay. So expand the outline form first. Remove any caries on the axial wall. You want to still avoid caves, but working with anterior teeth, unsupported enamel is a little bit different. You can get away with a little bit more of a shell or even a cave just because the pressure that your patient's going to be putting on the anterior tooth is a lot different than the pressure they're going to be putting in the posterior. So like I said, you can have a really thin shell on the front and that preserves aesthetics, which is a good thing. And you can also have a little bit of a cave there at the axial wall as you go in to remove any decay. After you take out the decay, what you always need to do, and I didn't include this as a step, but it should be, is you need to go back and you need to reassess your retention and resistance form. And so it's going to be important that you go back and smooth walls that need to be smoothed. If you can reasonably remove undermined enamel, you can do that at this point. And at this point, you might decide to put in retention grooves or bevel and, those kinds of things. But you need to have a moment where you kind of wrap everything up, make it really pretty to show your instructor. When you're practicing on your own, you do it for your own satisfaction to know that you did the best job that you could before you restore. Finally, we're going to restore these class 3s with composite. And so this is going to be an opportunity to get your Mylar strip checked if you haven't had an opportunity to do that. So just a few pictures that I have of the decay that you're likely to find on this tooth. You can see here Dr. Miller prepped this mesial lesion to ideal. It's not perfect, but there's decay to be removed, right? So you're gonna finish that up at the end. On the right hand side, you can see the one on the mesial is actually totally cleaned out at this point. He did them one at a time. You can do both ideal preps at the same time and get those checked and then kind of start strategically working through the decay removal. We're not going to do modification sheets on this. If you want to kind of talk in terms of mods with your instructor, that's a good thing to do just to be used to that. But you can see where these are placed. The mesial is always going to be just a little bit more incisal than the distal lesion. That's just the nature of the placement of most contact areas on these anterior teeth. These two pictures show you kind of an approximate location of the decay. I think these teeth can vary a little bit. I think you can see that on the mesial side, it's not quite far enough into the dentin to really expose it, but you can see that it's mostly kind of in that axio-gingival line angle area on the tooth. And then on the distal, a little bit of the same. It's kind of creeping up on the facial wall a little bit too. And here you can see the final clean outs that Dr. Miller did for this tooth. So if you kind of go back and then come look at this one again, you'll see that he kind of evened up some of the margins just to keep things nice and smooth. Went back and removed a little bit of the undermined enamel that he had after creating creating caves during decay removal. So this is a reasonable size. These are not huge like that number 10 that we did at first. But it should be good practice for some practical decay removal that you'll see kind of in everyday dentistry. And then it's also a good opportunity to do some more indirect vision, to practice an ML on number 8, because you're going to be doing one of those as a part of your practical along with the number 30 MO. So if this goes quickly for you, that's great. Maybe it's a good opportunity to practice on the regular teeth so that you are, getting some work in to prepare for the practical that's going to be at the end of the summer. And with that being said, I've included some slides here. This one is just going over all of the ideal criteria that we're going to use. We're not using the max numbers. We're not taking out decay. This is just a regular Kilgore tooth with no decay in it. And we're going to use the numbers, the same ones that you used at the end of D1. So I've created this little graphic to kind of emphasize the specific numbers that we're using. You want rounded corners. You need to leave the incisal wall in contact. It's completely reasonable when we're working on these ideal preps that you have parallelism. So you want to try to have the incisal edge and the incisal wall and the gingival wall all parallel to each other. And then you want to try to have your axial wall kind of paralleling that curve of the facial margin on the outside of the tooth in the box. And so one of the pitfalls that I see a lot is to have kind of a C-shaped prep. And that's not what we're looking for. We're looking for a rectangle that just happens to have rounded edges. This is from a past practical, and I just took some pictures of varying teeth just to kind of show you what we see sometimes in practicals and let you train your eye a little bit to see the good and the bad and the ugly. So if you take a look at this one, it's a little bit on the blurry side. I think it's an appropriate size. I think that they have broken facial contact. I held my finger there so that you could see a clear distinction, that it was broken all the way through the gingival contact and then all the way up to that incisal wall where the tan of my finger, the pink of my finger, kind of stops, and you have the incisal wall in contact. So that's what we're looking for. You can do that with your mirror. You can put your finger on the facial surface and try to make sure that you can see that line going all the way up to that incisal contact. This prep, I think, is maybe a little on the narrow side. I can see a little bit of that facial contact being broken. I do like some of the parallelism involved. It's definitely a rectangle with rounded corners. So it has some good things going for it. This one you can see is lacking that parallelism. So for sure the incisal wall and the gingival wall are at angles to each other, and you have a parallelogram with kind of rounded angles. It's a little sharp on that gingivo-axial line angle, but the facial wall is broken, so that's good. The incisal wall is still in contact. It does appear to me from this view that the facial wall is not exactly flat, just kind of has that look to it. So I definitely want to pick up my Explorer and feel that to verify what my brain is seeing. Ooh, here we've got some nice parallelism. It's definitely a rectangle with rounded corners, but the gingival wall does not necessarily look broken here. I can see a little bit of daylight. Some of that countertop is peeking through at the facial wall, but I'm not seeing an open contact at the gingival, and that will end up being a critically deficient on 8X. And so it's really important that you break that gingival contact, at least for ideal, up to 0.5. To max it out, it would be more, but we're not worried about that for the practical. So keep it conservative, but please make sure it's broken and that it's decidedly broken, that we're not guessing whether or not we can see daylight through it or not. I included this one because it is too small. And I think that as students start to improve with their hand skills and they move beyond the larger rectangle that they had a hard time controlling, and then they're able to produce something really tiny, it can be tempting to do this on a practical because it seems safe. But it's not what we're looking for. And we need these dimensions to be, at least at the minimum. The risk that you have on, say, a practical that has decay on it is that you don't find it when you prep this tiny little ideal prep. And there's really no point in wasting your time trying to do something so small, because the risk is not finding the decay. So make sure that you are able to get it to the minimum dimensions that we're looking for. If there's not a minimum, like I don't think I have a minimum for the gingival contact being broken. It's like up to and including 0.5 millimeters. And that's fine. As long as we can see daylight, that's all I care about. But if we ask, to have a height that it's, at least 0.5 millimeters, then you want to have that. You don't want to be smaller than that for sure. Just a reminder to look from the facial embrasure for that little broken contact for your facial wall. It's really helpful just to find that, because not only does it confirm that you've broken the contact, but it helps you see the shape of your facial wall. And that can be sometimes hard to determine when you're looking straight at it in a mirror. Even if you feel it with your Explorer, sometimes it's just hard to get a good picture of what's really going on until you've had a lot of practice. But if you can see your line through there and, say, see that it's curved and that it's not completely flat, then you can go back and look in your mirror and feel with your Explorer and feel for that curve, and then kind of come up with a game plan of how you can flatten that facial surface. Here's a little bit better picture of really what we're looking for when we look in that facial embrasure. I think it's easy to think that uh, you've broken the facial contact when you haven't really all the way. I think it's deeper than most people think it is. So try to mimic this, try to find the same kind of line peeking through. And if you want to measure with your burr or with a probe and kind of have a goal of what you think that should be to aim for, I think that's totally fine. I don't like to give a number for that because that's not how we grade it. We're not measuring a depth. We just want to see that it's broken. And when it comes to patients, for sure, you might have patients with rotated teeth, and it might take a lot less to break a facial contact, and it might take more. So every case is kind of different, and there's just not a criteria as far as the depth for that. So look for it in the facial, in that embrasure. If you want to kind of develop a guideline for yourself, you're welcome to do that. Ooh, I think this one is a good size. It's broken gingival contact. The incisal is intact. It's got some parallelism, but if I'm going to be really picky, there's a little slight kind of concavity to the axial wall instead of being straight, or even potentially having a very slight, there's not a lot of curvature on that facial margin, but, a little slight curvature would probably be okay. So this is starting to look a little bit C-shaped to me. And that's probably one of the only problems that I have just glancing at this prep right now. Here's another peek through the facial embrasure. It's starting to get a little bit bigger, but I think for the most part, this is probably still okay. Here we've got another one that it meets a lot of the criteria, but I think you can see that there's quite a bit of tooth damage to the adjacent tooth. There's almost another margin that you can see there with that white paper behind it. So be really careful. I've got plenty of fender wedges, so if you can figure out the best way to break contacts and smooth bird's beaks and that kind of thing, using something like a fender wedge or even a Garrison band or a piece of Toffelmeyer, something to protect that area is a really smart thing to do. Ooh, another nice broken facial contact. Maybe a little on the curvy side. It's something I might go back and check with my Explorer, make sure that I can make that facial wall nice and flat. This one's looking good. I can see the counter through the facial contact and the gingival. It's just a little on the small side, I think. And if you've got a prep that's, just measuring a little bit small, and you've got these barely broken facial and gingival contacts, you've got room to make it just a little bit bigger. And so, you kind of have to go through a decision-making process. Do you lower the gingival floor to make it bigger, or is that going to take you past 0.5? Or do you raise the incisal wall to make it a little bit longer? It's still going to keep you in that incisal contact area, but you may need to also deepen that facial wall just a little bit to make sure that you've broken contact all the way up from the gingival floor to the incisal wall. This is a really nice placement. It's starting to get a little rounded on the axial wall for me, and I think there might be a little lip of enamel out at the gingival floor margin there in the proximal area, and so that would be something you'd want to try to smooth out. If you are hesitant to use a hatchet, which I think is probably a wise move, I like to try to get rid of some of those little bits of enamel in really tight places using something that's pretty small, like a 7901 or a Christmas tree diamond, just to smooth out that area. But it takes practice and control to get something that's so small in such a tight space. And that's something that you don't want to necessarily try for the first time on a practical. You really almost want to find yourself in situations where you have to remove a bit of unsupported enamel just so that you can develop the skills for whatever method you choose to use to do that. And I think as you watch, I had a student come and tell me they were watching some Dr. Stevenson videos and noticed he was using a hatchet a lot and was asking for feedback about, if we're supposed to avoid the hatchet, what are good options? And so it's kind of talking him through that. But I think it's important when you watch him and you see him having to remove a bird's beak. It's not like developing a bird's beak is a bad thing. Leaving a bird's beak is a bad thing. But, as he preps, as I prep, I have to deal with all of these things that are not acceptable in a final restoration. But in the end, I see it, I recognize it, and then I have a plan of how to take care of it so that I'm left with a preparation that has good resistance form, which includes not having unsupported enamel. Ooh, that's a nice facial wall. It's nice and straight coming through that facial embrasure. This class was kind of rocking it on the class 30s. This prep is just looking a little rough to me. I don't see kind of the crispness that I've seen in some of these other preps, especially when I look at the gingival margin and the facial wall. I think there's some smoothing up that could be done. In general, the shape and the criteria all look pretty good. But if you have the opportunity to, you cannot be afraid to go back in and smooth things up. That's a part of your skill set. And so if you have a mental block, of like, I don't want to touch it anymore because I might screw it up. Like, I get it. I totally get it. But if you practice enough ahead of time, then you should be able to kind of work through that and have a good feel for, when that moment is that you should stop. Because there's a lot of times when we're grading practicals and we're just kind of sad because we're like, man, if they just did this one thing, it would be an A, or it would be such a better grade. And so being able to recognize them is one thing, but then being able to have a plan and a skill to fix it really is something different. And so if you haven't developed that yet in different areas, I think that's important to think through. So ask your professors how they handle certain situations. Potentially ask a classmate that is generally successful and see if they have a different way to do it too. But it's good to try different things, but it's really important to figure out your method that works for you and your hands to accomplish every little task. This one's too small. I'm questioning whether or not they broke the gingival contact. And so that's an easy one. Just make it bigger and make sure that it's really clear that you broke that gingival contact. This one's getting a little big. It's a little on the 8X side for what we're going for this practical. So don't think 8X, think we're doing ideal. Would it pass 8X? Probably. Besides the size, the thing that bothers me the most about it, and it will bother Dr. Lillard and others in the clinic, is that it's like sharp angles in the line angles. And so you want to have that rounded rectangular look. I included this one because although you can see that broken facial margin in the contact and in the embrasure there, it's got a little lip of unsupported enamel there, right? Like it's kind of jagged. So that's your red flag to get back in there, maybe something like an inverted cone to smooth and just barely kind of edge it out towards that facial margin so that you can clean it up. This one's kind of small too. Use your whatever measurements you want to use. Measuring devices, you can use a 330 burr that's 1.5 millimeters. You can use your probe if you feel more comfortable with that. I know students have also been using some condensers, which is a good thing because those have some known measurements. I know Dr. Stevenson makes a kit that he sells that has these tools for measuring for these exams, and I think it's a little expensive. Would I purchase it for boards if I was having to take it? Maybe. But I don't know that you'll need that right now. I think you've got lots of options to help you confirm your measurements.